Thank you for tuning in to the HS Foundation's lecture series. The HS Foundation is a nonprofit organization focused on improving the lives of people affected by HS through advocacy, education, and research. Our vision is to live in a world where no one suffers from HS. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through the joint providership of the Pennsylvania Medical Society and the Hidradenitis Suppurativa Foundation. The Pennsylvania Medical Society is accredited by the ACCME to provide continuing medical education for physicians. The Pennsylvania Medical Society designates this virtual activity for a maximum of 1.0 AMA PRA Category 1 credits. Physicians should claim only the credit commensurate with the extent of their participation in this activity. To claim CME for this webinar, you will access the completed webinar button you received in your confirmation email. From there, you will indicate which webinar or webinars you viewed. This will then provide you with the link to claim your CME for each course. If you have any questions, simply email info@hs-foundation.org. Thanks again for joining us. The presentation is about to begin.
Hello and welcome. This is the Critical Moments Managing Hidradenitis Suppurativa for Emergency and Urgent Care Clinicians. Thanks for joining us. I'm Jocelyn Kirby. I work at Penn State and I'm the president of the HS Foundation. And I'm joined by Steve.
Hi, I'm Steve Dave Louie. I work out of Wayne State in Detroit, Michigan, and I'm a board member with the HS Foundation.
So thanks for taking some time, because if you're an emergency room provider, urgent care clinician, you not infrequently run into patients who have hidradenitis, even if they don't know it, and maybe you don't know it yet. This is a condition that is, I would say, misdiagnosed and is there more often than I think we realize. So we're going to help you recognize this condition when it walks into your office, and how you can actually really crucially give these folks a name for what's happening to them and give them some treatment and hope. So disclosures, this program and presentation were developed with the best level of evidence available for hidradenitis. For personally, Dr. Dave Louie and myself, we do some consulting for the next generation of therapies that are being developed. And so you can see our personal disclosures in text on the website near where you found this talk. What we want to try and talk about is, how do you recognize hidradenitis suppurativa? What are some of the clues in the person's history? What are some of the clues on the person's skin? And then understanding what this condition is, maybe more importantly, what it is not. And we're going to break up some urban myths around this condition. And most pragmatically, Steve is going to give you a whole lot of information about what you can do for hidradenitis when you are seeing that patient. So talking first about what HS looks like. We put some information on each one of these subsection slides. Usually includes a little take-home point, like HS is a chronic inflammatory, not infectious disease. And we tried to sprinkle patient quotes throughout. For this one, patient was informed that their boils were happening because they were overweight. And so there's a lot of urban myth wrapped around, does weight contribute to HS? Does smoking contribute to HS? Many of our patients have been told, if you just lose weight, if you just stop smoking, if you just washed better. These are all statements that are really easy for us to say as clinicians, but aren't rooted in actual science. And number two, sometimes make patients feel so stigmatized that they actually don't go back to a physician for a while suffering with this really painful disease. So again, what does HS look like? And then we'll get into why it actually happens. So a lot of the people who develop HS are in their teens and 20s. A lot of people develop this disease for years before they even come to a clinician, like your emergency department, where they finally come in because something's just so painful. They probably already had it anywhere from 1 to 3 years before they see that first clinician. Although there are a group of people, and there are other chronic skin inflammatory conditions where there's a peak of people who get it in their teens and 20s, but also a peak of people who get it later in life around their 50s or 60s. And we're finding that's also the case with HS. It's not just a condition of younger people. What do people develop? They have these inflammatory nodules and abscesses that look for all the world if you just saw one of them like a bacterial abscess. But what you also see around these lesions, and you can see in the photos on the lower part of this slide, are their scarring, because it's been happening again and again and again. There's tunneling, like this lesion on the right-hand side. This is what looks like a nodule, but when you touch it, there's actually a firmness, a cord that's kind of linear, elongated along this underarm. And then around these lesions, you can also see comedones or blackheads. Comedones under the arm or in the groin are HS until proven otherwise. You might expect to see comedones on the face, the chest, the back when it's typical acne, but when it's happening under the arms or in the groin, it's hidradenitis. And the other name for hidradenitis is acne inversa, again, because of these morphologic lesions that are kind of shared between the two diseases. But HS is different from acne, much more intense lesions, bigger, deeper, like the ones you can see in this picture, but happening also in folds of the body. So under the arm, under the breast, between the breasts, the groin, fold of the groin, the genital area, and the buttocks. So all these different folds. HS, again, I kind of mentioned why people are showing up in your emergency department or urgent care, and it's usually because of the pain, and more pain. They finally just can't handle the amount of pain that they have. Many patients, when they come in to see us and you ask them how much pain do you have on a scale from 0 to 10, it is not uncommon that they will say 7, 8, or 9, or 11. And what you might see on their skin is a spot like this. And it almost can seem like pain out of proportion. And so when you see somebody who's having that much pain with scarring, with lesions like this, I would say hidradenitis is on your short list of the differential. But these patients also importantly can have a lot of itching. That's a sign often of the inflammation at the start of a flare-up, then it becomes pain, and then it's itch as things are resolving. So you can have both. A lot of patients are affected by the drainage. So when a lesion like this one finally comes to a head, it'll drain. That means standing on clothes. That might mean odor. And these are things that often in our culture and our society are not acceptable. And so this makes people very leery of being close to other people, whether that's a child at school who's afraid of raising their hand because somebody might see their HS or smell their HS. I don't think that feeling goes away when you're after 6th grade, whether you're 26 or 36. You don't usually want to have an odor. And so I have patients who don't sit at the table at a work meeting because they're afraid if they get too close to somebody. So pain in the emergency department, but these other symptoms are still really important. And then chronic and recurrent. So how do you differentiate HS from a typical maybe MRSA boil? Well, one of the questions you can really ask is, how many times has this happened before? And usually the person who comes in with this exam on the day they see you, they'll say, this has happened 5 or 6 times before in the exact same area, that same fold of the body. And so it's pretty typical for people, if you ask them, how many times has this happened in the last 6 months? They'll usually say 2 or more, and that's usually pretty diagnostic for HS. So HS statistics, we used to think of HS as rare. It probably isn't. Probably the best estimate for how frequently HS happens is around 1%, 1 out of 100. Might not sound like a lot, but that's about the same prevalence as vitiligo, as half as common as psoriasis. That's as prevalent as rheumatoid arthritis. So really not as rare, I think, when we compare it to some of these other conditions that you might see or hear more about. It is more common in women than in men, but both men and women, female and male, can have mild disease or severe disease. It is more common in Black or African American patients compared to white or Caucasian patients. And it's really important for us to try and recognize this, even in some of the youngest people who are developing HS. part of our issue right now with our research on HS is that it's taking people so long to finally get to the physician or get a diagnosis. We're actually missing the fact that people are getting it when they're 10 to 12 years old even. So if you work in a pediatric emergency department or see children wherever you work, please know that this is happening kind of right around when puberty is hitting. So breaking up some of these urban myths, because they really present a barrier to somebody showing up the next time they have a flare-up, or knowing that this is actually a chronic condition and I should follow up with that person you referred them to. It's not just once and done or twice and done. So as you're talking to the person, I would say very frequently people are coming in to see Steve and I, and they've been told you need to stop shaving and using antiperspirant. Actually, there's really very little data to suggest that this contributes to why HS happens, or if that stinging and burning happens when you use an antiperspirant. I think helping people understand it's really just the broken skin, not that it's always going to cause flaring. People are often told they need to stop wearing tight clothing. People with HS, they have very different approaches to what clothing feels good to them or doesn't. I have some people who say a tighter, legging helps to hold the lesion in place so it's not moving as much when they walk. Other people find that tighter clothing doesn't feel good to them. And so I tend not to be dogmatic about any of the things on this list, and certainly not hygiene. So HS is not a disease you can simply wash away. I think that it's the same for acne. If you've ever heard a teenager told they need to wash their face better and they get rid of their acne, that's not true. Acne happens because it's an inflammatory condition. And that's the same for HS. So you can't wash HS away. Smoking, it's a little bit, I would say, controversial. There's some data to support that smoking might bring on HS, probably that it might exacerbate HS, but it was not the only cause. And conversely, there's also no real great evidence to show that if all patients with HS stop smoking, that it would totally go away. Once it's there, we really have to treat it in some other ways. And so when it comes to smoking with obesity, which is on this list, our general approach is let's help this person have better health. That certainly means smoking less and having a lower weight. But while it's easy to say you need to stop smoking and you need to lose weight, those are hard things to do when your HS is so painful that you can barely walk across the room. So those are things that, Steve, I'd love your thoughts on this. That tends to be a second visit conversation for me. So for somebody who's showing up in your emergency department, I think your opportunity is give them a name for it and give them a bridge therapy. But Steve and I will kind of cross that road when it comes to what are those modifiable health factors that we can talk about at the follow-up visits. But Steve, what's your thought on that?
I totally agree. Yeah, it's much easier for us once we've established an ongoing relationship and some trust with patients to have those kind of more difficult conversations and avoid any stigma that comes with them because we already have a good working relationship. So I totally agree. Those things are things that you can leave to us.
Thanks. And I would say the sexually transmitted infections, there's a very important, I would say, minority or sometimes majority of patients who come in to our clinics and say, you know what, I didn't go into the provider right away because I was afraid somebody was going to tell me this is a sexually transmitted infection because it's happening on my thigh or it's happening on my genital area. And so I think we need to get the word out, this is not a sexually transmitted infection. When we look at it in our emergency departments and urgent cares, the morphology, the appearance of these lesions is really inconsistent with most sexually transmitted infections. And so throwing the gamut of, tests at them, I think only perhaps serves to make them think somebody thought that this was an STI. So again, all of these barriers, these concerns that both happen in patients and we're trying to break down, but also I would say misinformation that's been given to patients from providers who just didn't know what HS was, means that most of our patients have 5 to 7 visits before they are actually given the diagnosis of HS. And Steve and I, our whole foundation is really doing this so we can change that number. That the mean delay in diagnosis from the time they start with symptoms is 7 to 10 years, again, without having a diagnosis, without getting to standard of care therapy. And again, since 80% of these patients are not coming to a dermatologist, they're showing up to somebody else. And so that means that most people with this condition are going to see somebody who's not an HS specialist or a skin specialist. And I think one of the biggest things that we want to try and do is, keep people out of the emergency department, because if people are not under control, if their inflammation is causing them to have so much pain, they're in the emergency department, it means they're probably not at work. And so a lot of our patients suffer missed days of work, they're passed over for promotions, or they're even let go from their jobs. And again, that's where most of our patients get their insurance. So they need the jobs for the insurance so they can get care for their health condition. And I'm going to hand it over to Steve to talk a little more about diagnosing.
Thanks, Jocelyn. So the good news with diagnosing HS is you can completely do it. It is not a difficult diagnosis to make. It just needs to be on your radar so you can pick up early cases or see the whole picture for the patient. So again, it's a chronic inflammatory skin disease, not an infection. And this is another quote from one of our patients that said, "I was told that they weren't sure what to do with me." And that's unfortunately one of the problems that patients with HS have faced over the years, is there haven't been super effective therapies, and there haven't been a specialty stepping up and taking ownership. But dermatology is doing that now, and we are really taking ownership of this disease. So hopefully by the end of this talk, you'll be able to easily diagnose, know what steps to take, and what to do afterward. So this was based on a questionnaire study that made it very simple to make the diagnosis. Just ask a patient, have you had outbreaks of boils like the ones you're presenting with in the last 6 months? And then you can ask how many they've had and where they've had them. And if they've had 2 boils in any of those areas, the fold areas, then there's a positive predictive value of 96% that the patient has HS. What's also good is, if you diagnose someone with HS, you're going to refer them to a dermatologist to see to start their care. So even if they don't have HS, if someone is having more than 2 boils in 6 months, they should be seeing us anyway, because there's something going on there that's not just an acute one-off infection. So Jocelyn already highlighted some of the things you can look for on the clinical exam, some of the presenting signs. So the typical lesions are those inflamed nodules, which are sort of balls of inflammation, little swollen areas. Abscesses, which are similar, but they have that fluctuance. And like Jocelyn said, they look just like a bacterial abscess if you just get up close and look at the single lesion. Then those draining or even non-draining tunnels. Sometimes they're actively draining, sometimes they're not as active. Scars, which is a big clue. There's often scars from previous lesions that could just be a discoloration type scar, a change in the skin texture. And then as Jocelyn mentioned, those comedones, if you see comedones in the skin folds, they don't usually show up there. And comedones are blackheads. These double or tombstone comedones are where you have sort of one white bump and then multiple blackheads connected underneath. And if you have a hard time remembering that, remember that HS is sort of this disease that tunnels underneath the surface. So that's like a micro version of it, where more than one blackhead is already making a connection underneath. Then the typical locations we mentioned, the axillae or armpits, intermammary folds, the groin, genitals, buttocks, all the skin folds are the typical locations. But it's good to keep in mind that not every time does the disease read the textbook. So you could have HS with atypical lesions that don't look as large, such as folliculitis and more of like an acne-ish picture, but in the typical locations. So this is a picture of sort of this acne folliculitis on the buttocks that was actually a different presentation of HS. Or you could have typical lesions, which are your nodules, abscesses, tunnels, but in atypical locations. So sometimes it extends beyond the typical areas, and you get it in your waistline, the neck, behind the ears, on the thighs further down. So don't rule it out if it isn't the perfect picture of HS, and keep it on your radar if you see things in those typical locations or typical lesions. And of course, if you see both, then you think, all right, this is HS that I'm dealing with. So touching on some of the things in the differential, we mentioned the bacterial abscess because abscesses look and feel like abscesses. They're this fluctuant, swollen area under the skin. So what are some of your clues? One is the chronicity. Ask if they've had them before, especially in these same typical areas, or is this a one-off? Usually a bacterial abscess happens to people once, maybe twice in their whole life. Often a bacterial abscess also has a preceding trauma, which is how the bacteria got into the skin. Our skin puts up a pretty good defense unless it's broken and then things get through. Whereas with HS, there's often not a preceding trauma to the area. And then of course the distribution, where are these located? You know, an abscess on the shin is pretty typical when someone bumps their shin on something, but abscesses in the axilla and groin should make you pause and ask those questions. Have you had these before? Have you had more than one of these in the past 6 months? Inflamed cysts can look just like an HS nodule or become fluctuant like an abscess. Typically, the patient can describe that they've had a cyst there for a while, and then recently it became more angry and red and swollen and painful. But I've had kind of a bump under my skin that didn't bother me for a long time. So that's one of those clues that it might be an inflamed cyst. If it kind of sounds like it was a normal cyst and then this inflammation is newer, a lot of times the distribution will also help with that, because these tend to be other places like the chest and back and scalp. And then folliculitis can be a little bit tough because, as we said, in certain areas, if you see folliculitis that are typical areas for HS, you actually should think HS. But if you see folliculitis that's more in the sort of acne distribution of chest, back, shoulders, then it's probably not HS and it's just folliculitis. But it doesn't hurt to make sure you examine those sensitive areas for HS, or at least ask patients about those areas, because you'll be surprised how many times patients could have HS in a sensitive area and they just aren't bringing it up, kind of thinking, I'm here for this lesion. It's a little embarrassing to show these areas. I'm afraid of how you might react. So making sure you're asking if there's involvement in those other areas is really important on every visit. And then pilonidal sinus or pilonidal cyst is very similar to HS. They're even in the same family. So it's basically a little sinus or cyst right at the top of the gluteal cleft, but it's in this family of HS, of follicular occlusion disorders. So people who have pilonidal sinus are more likely to have HS and vice versa. So when you see one of these, some people just have the pilonidal sinus, but again, that's a good time to ask about lesions in other areas. HS can sometimes mimic cellulitis because there can be a lot of inflammation causing a lot of erythema. And some patients actually even get sort of a contact dermatitis from the discharge of their HS that then looks more red and angry. So usually cellulitis is unilateral, not bilateral, and HS is typically bilateral, not always, and not always equally symmetric, but often it's bilateral. And cellulitis is, again, sort of like bacterial abscesses. It's more of an acute episode. This just happened. It's getting red, swollen, warm, and spreading, versus HS is this chronic course that kind of clues you in. And then the last image there is actually Crohn's disease affecting the skin. So it can be very similar to HS because this is in the inguinal fold. And you see this, we call it knife cut ulceration, where it actually looks like the skin split open. So that is a clue that it's actually cutaneous Crohn's disease instead of HS. And while the ulceration and the distribution kind of makes you think HS, it doesn't usually have the typical nodules and abscesses that we see in HS. The good news is if you see cutaneous Crohn's, that patient still needs to see a dermatologist to help get it under control and see their management options and maybe even get a biopsy to confirm. So either way, those patients need to follow up with a dermatologist. And then I'll pass it back over to Jocelyn to touch a little bit on the pathogenesis of the disease.
Perfect. So I think Steve just reinforced really nicely. When something is an infection, it's often asymmetrical, and it's usually a bit of a one-off, like it happens once or twice in your lifetime. When something happens symmetrically and top to bottom symmetry, not just left to right symmetry, usually says there's something more internal happening. And so why does an abscess even look like an abscess? Well, it's because our immune system is reacting to the MRSA or the bacteria. So I often let people know when they have HS, this is from your immune system. It's just working too well. It's kind of overboard. And so I think for two reasons, it's important for us to realize this is not an infection. Again, you can't wash it away. And we need to help people realize that their bodies aren't broken, because sometimes people have not been given this information. They've concluded, I keep getting infections over and over and over. It must mean that my immune system is broken or deficient. And so it's not uncommon that people have been told, as you can see in the quote here, I was told the lesion was infected. I was told it needed lancing, packing, and antibiotics. And so we're going to unpack this a little bit, pun intended, because Steve's going to talk about how we don't need to pack things later on, but also to help people realize that they aren't infected, they're inflamed. And so this is a simple schematic that breaks down some of the main steps, the most crucial steps in HS as we know it right now. Now, this science is being done and changing moment to moment. But what's important is that the hair follicle seems to be the focus for the inflammation. It's not the sweat glands, which the special type of sweat glands under the arm and then the groin, they actually drain into the hair follicle. The ones that keep us cool and are distributed over our whole bodies, they actually drain into the skin surface. Occasionally, people with HS notice that sweating makes it worse. That's probably true because of skin friction. It might trigger inflammation, but the actual sweat glands that people often think cause HS drain into the hair follicle. So again, this is really more a hair follicle disease. When there's inflammation in the lining of the hair follicle, it causes the dead skin cells not to be shed out of that open channel quite as easily. Instead, they get plugged. And that plugging starts microscopically, but then becomes visible. Those are the blackheads that we see under the arm and in the groin. And so while you don't see a lot of pinkness in the skin around those plugs, those comedones, it's there. It's just subclinical. And so that inflammation is causing the plugging. If inflammation is not corrected, it can become even more, disrupt the hair follicle. More of the skin cells that should have been shed instead aren't, burst under their skin, very similar to an inflamed cyst. And then if inflammation is even more robust, instead of just having one nodule or one hair follicle that's inflamed, you actually have a whole mass of inflammation. And this is what we see when we see tunneling and you get the scarring that happens over top. I think one of the most important things is to recognize, and we put a box around this, that again, this is an immune system condition that is supported by the chronicity, it's happened by the symmetry, supported by the science. And so the cytokines that we see upregulated in this condition are numerous. Seems like HS is one of the most complex immune system conditions that we treat as dermatologists. And so you see TNF alpha in this box, it's interferon, interleukin 12 and 23, interleukin 17. We're finding even more cytokines and more cell types that contribute to this disease all the time. I think the take home for you all is we're still learning what the real pathogenesis of HS is. But what you can let that patient know is that this isn't an infection. It's not from not washing well enough. It's not from having an infection and bacteria on your skin that you didn't get rid of. It's not going to be cured by the 17th antibiotic you take. What we want to try and do is treat the inflammation. It has a name called hidradenitis, and there's probably a dermatologist or another expert in your community who can help you manage this over the months and years that it might be happening. And that leads to Steve. He's going to give us some of the tips about how to manage these patients when they show up in your emergency department or urgent care.
Thank you, Jocelyn. And this is one of my favorite patient quotes that came from one of Jocelyn's patients is, HS is the roller coaster from hell. So as we're going to talk about, it has flares and then kind of better days for a lot of patients, but it's just unpredictable and you don't know when it's going to flare up. So you're just constantly in fear of your next flare up. How bad is it going to be? Is it going to happen right before a job interview? It is just a nightmare to live with a disease that's so unpredictable. But hopefully we can give you some management tips that will help you to manage the acute disease. And we'll also talk a little bit about the other options we have, just so you know that you can share with patients. There are treatments out there. Don't lose hope. So a lot of times when they come to the emergency department or urgent care, it's because they're having an acute flare. So what does an acute flare look like? It could be just one abscess. And in which case, that's when it can be kind of tough to differentiate it from a bacterial infection. And you need to ask those questions about chronicity and recurrence. Or it could look like multiple inflamed lesions like this axilla, where you can see there's nodules and there's scarring and there's lots of inflammation. And often that flares come with inflammation and pain. and drainage as their big symptoms that are bringing people in. And like Jocelyn said earlier, that pain, they need some relief from the pain. So this is why it's so important to recognize HS early, is because you can see from the bottom on the x-axis there, we go from disease onset to early disease to late disease. And the inflammation in HS causes permanent damage and permanent changes, scarring and tunnel formation that are progressive. So that's why we want to treat early in this window of opportunity to make the diagnosis and start treatments to halt progression before a lot of that permanent damage is done, when we can still intervene early. That's not to say we don't have treatments for late stage disease, because we certainly do, but we want to stop that progression as much as we can by making the diagnosis earlier and getting them on treatment earlier. So this is why it's really important that we're catching people when they may not know that they have HS or have ever even heard of it, and they're just going to the emergency room thinking they have an infection in their armpit, and they had one, 2 months ago in the other armpit. What's going on? So that's where we really want to seize that window to get treatments started. So treatment is often based on staging, and this is the Hurley staging system. It was originally developed as sort of a surgical assessment to see who's a surgical candidate and who isn't, but it works as a really good sort of surrogate for severity and to help us make some treatment decisions. So Hurley stage 1, you have either single or multiple lesions, but there's not much tunneling or scarring between them. So it's just kind of spots popping up here and there. When you get to stage 2, you start to see multiple lesions with tunnels and some scarring. So that's where it's definitely easier to start making the diagnosis, because you're seeing that permanent damage. And then stage 3, it basically has taken over the entire area. So in this case, it's an axilla where you can see the disease is just confluent throughout the whole armpit. So it's diffusely involving that area. For all stages really probably can benefit from some medical therapy, but especially stage 1, you're going to focus on medical therapies. Stage 3 is probably going to need a combination of medical and surgical, and stage 2 will probably need a combination too, depending how they respond to medical therapies. So most patients require a combination of medicine and surgery. The medicines go after that inflammation, that systemic inflammation, and try to calm things down. So that shows up as a reduction in the number of new lesions, an improvement in the symptoms, the pain, the itch, the drainage, the odor, the visible signs of inflammation like swelling and erythema. It's really calming down that inflammation. And then sometimes we need surgical procedures to sort of clean up some of that damage that the inflammation has done. So it can help with symptoms, and it can really help with persistent lesions. It seems like my disease is really calm, but I have this one draining tunnel that just keeps draining all the time. Or I have this one abscess that just keeps coming back in the exact same spot. Those are ideal for some of our surgical interventions. And there are some that you can do right in the emergency room or urgent care, and then some that will be more in the dermatologist's office, and even some that might require the operating room. So we'll really focus on some of the ones that you can do in the emergency room in a little bit. And this is a great diagram that comes from the North American Treatment Guidelines for HS. And I want to point out that if you go to the HS Foundation website, which is hs-foundation.org, you can get these open access articles for free. So that way you can get the articles, read up, and get familiar with the treatment of HS. Even if you're not going to do all the treatments, it's sometimes even nice to show this to patients, because the message we want to make sure we're giving the patients is that there are treatments. I'm sure Jocelyn can attest. A lot of patients have been told, there's nothing I can do for you. There's no treatments for this disease. You just have to wait until it gets bad enough that the surgeons will do big surgeries and cut out all your glands and cut out your whole armpit. And we really want to sort of fight that myth, because there are medical therapies and we're getting more and more. And there's a lot of research and a lot of promising therapies that are coming to market for this disease that can really change the path that patients are on, especially if we can do it during that window of intervention. So across the top, you can see those Hurley stages, 1, 2, and 3 that sort of match up with mild, moderate, and severe disease. Then on the left, you have medical treatments, procedural treatments, and treatments for acute lesions. So as you can see, across all stages, we have options for treatments, and therapy tends to intensify more as you get to the more severe stages. But we're going to talk a lot about the acute lesions because this is when people are presenting to the emergency room or the urgent care. They need something acutely done to help them out. So what can you do now for the patient that's right in front of you? One option is going to be intralesional steroids, and we'll talk more about that. One is going to be incision and drainage. And a quick note here, but I'll emphasize it again. You don't need to pack it. You do need to numb it. Antibiotics and prednisone can also be options that can help with flares. And then we have a patient quote here. Because of the location of the boil, I was really embarrassed to go, but I was in so much pain. So that's another good thing to remember with patients is try to put them at ease when it comes to the exam. It's a very embarrassing disease that can cause a lot of internal shame in patients. So it's hard for them to even show you these areas. They're nervous about what your reaction is going to be. So make sure you kind of put on your game face. And when they show you, say, don't worry, I've seen this before. I'm familiar with your condition. We have some treatments we can offer. No need to be embarrassed because it's a tough one for patients. So some of the things you can do now, intralesional steroids. This is something we do a ton in our clinics when patients have a flare-up. And we tell them, if you have a flare-up, you call us. We'll try to get you in that day or the next day to get an injection. So this was one of the early studies on it where they used intralesional triamcinolone at a concentration of 10 milligrams per milliliter, and they checked back over a week. And they noted that there was a decrease in the redness, size, suppuration, edema, and pain that was significant at days 1 and 2. So that's usually what I tell patients. If you can make it through this shot, and it's a little bit uncomfortable when we do it, you're going to see an improvement in the next 24 to 48 hours, and you'll get some relief. Sometimes the injection also serves to drain the lesion if you sort of puncture through it, if it's fluctuant. So that can kind of serve two purposes at once. And then here's just an example from their article of a suprapubic lesion that you can see at baseline was very red and angry and inflamed. And by day 7 was much calmer. The dose that you use is often between a quarter to a full cc of the triamcinolone, depending how big the lesion is. As I mentioned, it can be a little bit uncomfortable going in because there's already some swelling in the area, but it's usually not very uncomfortable. So as long as patients can sort of tolerate the pain of the needle stick, they usually do really well. If it's a nodule, you can go right into that swollen mass and inject there. If the lesion has more of a cavity, like say it's an abscess or a tunnel that you're injecting, you don't want to put the medicine in the cavity because then it's just going to ooze out like the pus does. So you're better to put it a little bit below it, sort of through the base. So if you went into the lesion, you can go through the floor, or you can sort of go next to the lesion and get under it so that it stays underneath there and kind of serves its purpose and doesn't just flow out. If you start injecting and you notice it coming out, just push a little deeper to penetrate through the floor of the lesion and then deposit the triamcinolone underneath. So it's a great...
Steve,
yeah.
I wanted to jump in on this one real quick because I think if we remember back to school, you know, we used to laugh about dermatology and skin disease and say, oh, just rub a steroid on it. Well, this is basically the same thing, except now we're injecting a steroid into it. So I think that steroid injections are kind of under-recognized and underutilized outside of dermatology for a lot of skin conditions. HS is the one where injections of steroids are just going to help your patient a whole lot. And if you are injecting anything into joints, injecting the skin is so much easier because you're just going, to Steve's point, right under that nodule, and it's gonna, the diffusion will do the work. So skin, steroids, just instead of rubbing it, injecting it.
Yes, that's a great point. And don't be nervous because like Jocelyn just said, you already have the skills and the skin's pretty forgiving. If you're in the general right area, it's going to work. It's not as precise as some of the other injections you have to do. So it's an easy thing to pick up and try. And once you see the benefits for patients, you won't regret it. How about incision and drainage? So incision and drainage can be helpful for those acute lesions, the abscesses that need some relief. The most important thing is you can numb the area first. There's sort of this conception, especially in bacterial abscesses, that, oh, because the bacteria change the pH, the lidocaine doesn't work as well. And that is true if you're right in the middle of it. But the surrounding skin can still be numbed, and that's where they're going to feel the procedure. So when you're numbing, you can go and numb your incision site. So you can go just barely under the skin surface into the dermis and inject the lidocaine there, and you'll actually be able to see it filling the skin overlying the lesion. And that's really important because that is the skin that's going to have sensation. And then you can go a little bit deeper and get some in the deeper areas so that once you're kind of doing the procedure, they won't feel anything at the bottom. But please, please, please don't ever attempt an IND for any reason without numbing. Patients do feel the pain, and it is less painful when patients have numbing. So it's an important step not to skip. Then when it comes time to make the incision, you can use a scalpel, or if you have one of our punch tools, you can do a little punch to kind of open up, express all that purulent material, which usually gives some immediate relief of the pain. And then there's a procedure that we call de-roofing. It's almost the same as an IND. An IND, you're cutting a hole in the roof of the cavity and letting everything out. De-roofing, you just take the rest of the roof off. So it's a very simple procedure to convert to, where you just take the rest of the roof off and then let it stop the any bleeding you have and let it heal by secondary intention, where you don't have to pack it, you don't have to do anything, and it'll heal in, and the recurrence rate is a lot lower. Because for an incision and drainage, the recurrence rate is somewhere between 24 to 100%. So most of the time, that lesion will cause problems again. The skin heals, it's still there, it flares back up. And sometimes patients get discouraged by that. They'll say, I've had over 100 surgeries for my HS, because no one told them that this is almost certainly going to come back after I do this. With de-roofing, the recurrence rate drops down to 4 to 17%. So it's a quick, easy add-on you can do to make things go a little better. And sort of a modified version is to do your IND or open up with the punch tool, and then take either a curette, which is a little scrapey spoon type tool, or you can wrap some gauze around a cotton tipped applicator and just kind of scrape the inside of the lesion. And we think by disrupting that lining, that leads to a lower recurrence rate versus just draining it and letting it fill back in and then heal up. No need to pack HS incision and drainage. Packing is mostly meant to sort of keep a bacterial infection open so that the bacteria can't set up shop again. But as we talked about, HS is not an infection. It looks like it because it's the same part of the immune system, like Jocelyn said, but it's not an infection. So no need to pack it. Packing adds extra discomfort for the patients the day you do it, the day they have to remove it. I don't know if you've ever heard the horror stories from patients and family members about removing packing, but it's usually a very traumatic event that causes a mess in their bathroom, and they never forget how horrible it was. So no need to pack abscesses for HS. It has no additional benefit. And then, like I said, make sure you kind of tell them ahead of time, if I'm doing an incision and drainage, this gives you temporary relief. There is a good chance that this spot is going to come back. So it's good for them to have follow-up with someone who's going to take care of their HS more long-term, because this is just to kind of give some symptom relief.
Steve, can I reinforce just, I think, 2 important points here, which is if you don't change anything else about what you do, you can do the same incision. Maybe you don't have punch tools. Maybe you're a little leery of, scraping it out. I would say stop packing because, it's one of the main reasons why I've had patients not go in to get care again, because they thought the next time someone was going to do something, they were going to pack it. So you save yourself some time there, and you can take that time and put the lidocaine in, because that's the second most common reason why people are afraid to go back into urgent care or emergency departments again. They said, somebody cut me, they didn't even try to numb it. So we know it's not going to be perfect. That numbing, the pH, it's not going to be perfect. It's the attempt. And so put a little lidocaine in, you'll save yourself some time on the back end by not packing it. But those are crucial, I think, to help people get through the experience and not be too put off for the next one.
Yes, those are the big take-home points. Numb it, don't pack it. And then systemic antibiotics. So why are we talking about antibiotics if it's not an infection? A lot of our antibiotics have strong anti-inflammatory properties. And we've shown in some of our skin diseases that you can actually sometimes even use doses that are so low they don't affect bacteria, and they just are anti-inflammatory, and it calms the skin down. There may also be a role for killing bacteria in HS because even though it's not an infection, it's not contagious, it improves with immunosuppression, all showing it's not an infection, bacteria may play some role in stimulating that immune response. So by killing some of the pathogenic bacteria that are sort of colonizing the area, it may help. Sort of akin to what we see in the wound literature, where sometimes these biofilms in the presence of bacteria trigger immune reactions that lead to things that won't heal. And if you can sort of treat the bacteria, even though it's not a true infection, it will improve. So these are sort of a couple easy, quick things you can use for discharging patients from the emergency room or the urgent care with something that will help their HS. Doxycycline, 100 milligrams twice a day. You can go up to 12 weeks. So that gets them enough time to get in to see a dermatologist because our wait times are really long and it's hard to get in to see us, but usually we can get you in within 3 months. You do want to warn them about the GI upset. Take it on a full stomach. If you take it on an empty stomach, you'll throw up. And then it can make you more photosensitive. So especially for people who are lighter skin types in climates that are very sunny, they might get a sunburn easier than before. And then clindamycin. You can use 300 milligrams twice a day, again, up to 12 weeks. You do want to warn them about potential GI side effects, including causing C. difficile infection. That risk is still not overall incredibly high, so it's still a safe thing to give people to calm things down. You can even recommend they consume probiotics while they're taking it to kind of help reduce that risk of C. diff. And again, it's a good bridge to getting them in to see someone for their HS. So it's something they can be on while they're going in. You'll notice both of them say up to 12 weeks. Neither of them says 7 to 14 days because HS is not the kind of disease that we treat with our infection dosing antibiotics. And one of the reasons that can be sort of harmful in the minds of patients is that reinforces to them that this is an infection. You're giving me a 7 to 14 day course of an antibiotic. That's what I get when I have an infection versus this shows, no, this is a chronic long-term disease. We need to keep this calm until you can see someone who can then start treatments that are going to last longer. And when they come to see us, they go, yeah, they get me antibiotics, but it was for 3 months. So I thought that was different. And we go, yeah, this is different. So those are kind of simple things that you can start when you're discharging someone so that they don't flare up right away and turn around and end up right back in the ER. And then prednisone, like Jocelyn mentioned, steroids work for inflammation. We know that. We don't love prednisone because it has long-term side effects, but for short-term, it works good for a lot of things. So we already talked about the intralesional injection. That's good if they have one or a few lesions, maybe 1, 2, maybe even up to 6 you can inject. If someone's having a more widespread flare with multiple lesions, it's better to go with an oral prednisone to kind of give them some relief and calm it down a while. So we usually dose it at 1 milligram per kilogram. You can give it in just a single morning dose because that's more in line with our normal circadian rhythm for our cortisol release. And then you can usually do it for 1 to 2 weeks. And that's usually an adequate course to calm down an HS flare. And you can combine it with one of those antibiotics I talked about too. So you can give the doxycycline or the clindamycin because the prednisone will work faster and give more immediate relief. And then the antibiotic will give sort of a lasting relief to get them through to that appointment that they're going to take. Now, what about pain? Pain is probably the reason the patient came into the ER urgent care. And pain, we know from our research, is the cardinal symptom. The symptom that patients say is the most devastating about their HS is the pain that it causes. They can have all different types of pain, and we're learning more about the mechanisms of the pain for that chronic dull pain versus that acute flare pain. But it's important to acknowledge pain that patients are having because sometimes it's out of proportion to the exam. A patient might be reporting that something hurts a lot. And when you're looking at it, it looks like an HS patient who said that they weren't having a lot of pain. But a lot of what happens in HS is under the surface. So you can't tell that they're feeling incredibly swollen and having a lot of pain underneath there. That's another good thing to mention is I always ask my patients about tenderness before palpating the areas for an exam. Because sometimes you need to be gentle when you're trying to feel what's going on under the surface in HS. And it's always a good idea to ask them, how tender is this before I start sort of feeling what's under the surface? And they'll let you know, and they'll let you know how hard you can push. So What can you do for the pain in HS? Number one, treat the HS. If we treat the underlying disease, the pain lets up. So that's always our goal, is to treat the HS. And hopefully now we've given you a couple tools between the prednisone, the oral antibiotics, the intralesional steroids that you can do to treat the disease itself. And then I think we've all become much more accustomed to how useful acetaminophen and NSAIDs like ibuprofen can be as we've tried to scale back our use of opiates. So a lot of times we'll have patients alternate these, taking the acetaminophen now, in 3 hours take ibuprofen, 3 hours the acetaminophen, and sort of that staggered schedule gives a good consistent pain relief. There's also some topicals, topical benzocaine and topical lidocaine, that patients can purchase over the counter, and they can sort of massage into the areas, and that can give them some relief too. So it's nice to have an option they can use at home. Some patients have reported cooling sensation of menthol containing creams can be helpful to relieve the pain too. So that's another good thing. And we'll talk about a little bit in just a minute about connecting them with patient support groups so they can learn what works for other patients, because that can be so invaluable. And then other things that have some evidence for the pain are gabapentin, pregabalin, even duloxetine and venlafaxine, because they can help with sort of that central mechanism of the pain. And then tramadol is a nice alternative to conventional opioids with a lower addiction potential. And then you may need to have the patient see a pain specialist. You know, sometimes when it comes to taking care of HS patients, it takes a village of providers to cover all the aspects of the disease. So if someone is reporting really bad pain, go ahead and refer them to pain management at the same time you're referring them to dermatology, because they'll just be able to get in to see us both earlier and get both areas under control better. And then maintenance management. So we bring this up again to say that there are other things that we can do. Make sure patients know that there are options. There's other antibiotics we use. We use the biologic medications, some that inhibit TNF and alpha, and we have some in development to inhibit some of those other cytokines that Jocelyn mentioned earlier. Sometimes we use oral retinoids or hormonal therapies that can help with HS. We have some of our procedures we do, including laser therapies and some local in-office things. So there are a lot of treatment options that to offer HS patients, but they need to establish with someone who's going to give them that ongoing management to treat this chronic disease chronically and get it under control long-term. But we really want to hammer home the point that there are treatment options out there for patients. It's not kind of a thing they should just be going to the emergency room for. They should be following up with someone for long-term care. And then there is one currently FDA-approved therapy, which is adalimumab. It is a self-administered subcutaneous injection that blocks TNF alpha. So these are the evidence from the trials, and the red line is the placebo. The blue line is the adalimumab. And this is the percentage of patients who achieved what we call the high score, which is a metric we use to show if something works. And it's a 50% reduction in their lesions. And what you can tell from the placebo is, first of all, HS is a disease that relapses and remits. So the placebo rates are sometimes high in our clinical trials because, as you may experience when you talk to an HS patient, sometimes they say, today's a good day, but last week was terrible. Or today's a horrible day, but I've been doing really well for weeks on end. So when you take a snapshot of a disease like this, sometimes it's not a totally accurate picture of the course over the last few weeks or months. The other thing we learn is that the adalimumab worked much better than the placebo. So you can see 41.8 to 58.9% of patients were reaching that endpoint of the high score. It's not a perfect endpoint because it's a 50% improvement, but some patients do better and some don't respond as well. But it's important that we have an FDA-approved therapy that we can use for patients. And it's important that they know that, because sometimes it's meaningful to patients to know that someone actually did studies in this disease and went through the FDA and got a medication approved to treat what I have, as opposed to just borrowing things from other diseases. So that can be powerful for them to know, no, there is an FDA-approved therapy and there may be more soon. And then this just shows the risk of flares. with adalimumab, and that it was able to reduce the risk of flares. So that's what we keep talking about, this long-term management to keep people out of the ER by getting the disease under better control and having them experience fewer flares with time. So you can see placebo is the blue lines and adalimumab is the grays. And you can see over time, there was a reduction in the flares that patients were experiencing, which is great. We want them to have fewer flare-ups. And then Jocelyn touched on these so great. Please try your best not to spread any myths about HS. People are already hearing this from providers who don't really understand the disease. So it's not an infection. It's not contagious. Your family members can't catch it from you. It's also sometimes helpful to tell them, if we actually, like Jocelyn said, if we block part of your immune system and bring that overactivity back down to the normal level, your disease will improve. So that's another sign it's not an infection, because if you bring someone's immune system down when they have an infection, the infection gets worse. It doesn't get better. She really hammered home the point that hygiene is not the cause of HS. There's a lot of shame associated with that, where people just are told that they aren't washing good enough, and that couldn't be further from the truth. Like we saw, the first step in the pathogenesis is those hair follicles blocking themselves up. That's not due to hygiene. That's due to abnormal skin cells. And then weight loss and smoking. As we said, there is a relationship between weight loss and smoking and HS, and sometimes it can make it better or worse, but it is not the cause, and it will not cure disease universally for patients. So let us be the ones who talk about the weight loss and the smoking cessation, because we can establish a long-term relationship and really talk to patients in a way that doesn't make them feel shame and stigma, that just isn't akin to a one-time visit that you're only going to see someone once at the ED. That's not the time where you need to talk about these risk factors. You can leave that to us, which I'm sure you don't mind, because it's never an easy conversation to talk about smoking or weight loss with somebody. And then it's good to recognize it's more than skin deep. Yes, it's a chronic inflammatory skin disease, but look at all the comorbidities that have an increased risk with HS: depression, anxiety, suicidality, substance abuse, tobacco use, arthritis of various types, inflammatory bowel disease, polycystic ovary syndrome, sexual dysfunction, metabolic syndrome, and even cardiovascular disease. So that's another reason we really need to get this inflammation under control, because this systemic inflammatory state is impacting other organ systems and increasing the morbidity and mortality in patients who have HS. So we want to get that under control so that they're not suffering from these other ailments, from all this inflammation that's just running amok. So as I mentioned earlier, dermatologists may not be the only person you're referring this patient to see. They may benefit from seeing a psychiatrist or mental health professional, especially if you get that vibe that they're having a really hard time dealing with the emotional strain that HS brings. Primary care physicians. I mentioned on the last slide, they're at higher risk for cardiovascular disease and metabolic syndrome. You want your dermatologist taking care of your skin. You don't want us being the one taking care of your cholesterol, your blood pressure, your diabetes. So it's important that these patients have a primary care provider. And sometimes when it's presenting in the teens and 20s, they may not have a primary care provider. We know that this age group doesn't tend to go to the doctor very much because generally they have good health. So it's important to make sure that you let them know that they should get a primary care provider. It's important for the treating their HS and for making sure that other things that can come with HS are managed as well. Social work can be helpful. Pain management, like we mentioned earlier. And then patient support and advocacy organizations can be so important for patients with HS. So I already mentioned the HS Foundation website, which is a great repository for vetted and reviewed accurate medical information that patients can access. And then there's some patient support groups that can be really beneficial. So here we mentioned Hope for HS, because it's a very isolating and stigmatizing disease, and it's really powerful for patients to be able to connect with other people who are going through this shared experience, and they don't feel like they're so alone in what they're going through, and to share those best practices. There's so many times where a patient tells me that they connected with someone through a group and they found out about this menthol cream or CBD cream that really helped them out, or how to, make their emergency kit in case they have a rupture when they're out away from home, or what kind of clothing to try to see, like Jocelyn was saying earlier, are you someone who does better with loose clothing, with tight clothing, with different kind of bra? So connecting with other patients can be so invaluable for these patients. And it's something I recommend everybody do. And with that, we just want to thank you so much for your attention, for having the desire to take care of these patients and to do a great job at it. hsfoundation.org, which is hs-foundation.org, has some great information. If you need to refer to this video again or any of our other resources, you can also reach out to us on social media or through email or through the website.
And thanks for helping us to take care of these patients.